Assalamu alaikum. Honorable Chairperson, Professor Titumia Sir, Director General of Medical Education and President Bangladesh Society of Medicine, Guest of Honor, my respected teacher, Professor Kaji Tarikul Sir, Professor Ahmadul Kobir Sir, ADG, DGHS, and Secretary General of Bangladesh Society of Medicine, learned expert panel, Professor Bilal Anum Sir, Professor Asadul Kobir Sir, Professor Ahmed Hasan, Professor Abul Kalam Azad, Professor Shamul Sir, and probably Professor Gulam Sir, and learned audience in front of me. And I must mention one name, Professor Nazmul Hasan Sir. He is my direct teacher. I want to convey my gratitude to Professor Nazmul Hasan Sir and so many teachers in front of me. Today I am grateful to Society of Medicine. They allow me to speak a few words in front of such a learned audience. My topic is managing chronic neuropathic pain, recent advances and new challenge. So, there is a definition of pain. It is unpleasant sensory and emotional experience. But I think the definition of pain is not enough. It has huge impact on our life. We have come here taking lot of pains to come here. I have come from Rajshahi. You have come from neighborhood. All of you have taken some pains. They also define International Association for the Study of Pain. They defines neuropathic pain as pain caused by lesion or disease of the somatosensory nervous system. But it is also not covered all. There is an arbitrary definition. If it is persists less than 3 months, it is acute, or if it persists more than 3 months, it is chronic. So what is the prevalence? Prevalence, it is 1 in 5 individuals suffer from chronic pain, that is more than 3 months. A substantial number of these patients experience symptom of neuropathic pain, that is 30 to 40%. So the prevalence of neuropathic pain, about 14.6%. It is more frequent in women than men and a higher prevalence in the age group above 50 years. Moreover, chronic neuropathic pain is one of the major reasons for medical consultations among Americans. Neuropathic pain causes major morbidity. In a recent study, 70% of those affected rated their quality of life as worse than death. There is a study in Bangladesh in diabetic peripheral neuropathy. 294 patients, type 2 diabetes, outpatient were studied. The overall diabetic peripheral neuropathy prevalence was 19.7%, with male prevalence 20.9% and female 18.7%. The prevalence increases with age, that is 11.1% at the age of 23 to 40 years to 32.3% in the age of 60 to 80 years. And the duration of the diabetics, it is 14.1% in the 5 years of diabetes to 29.2% in 9 to 11 years of diabetes. You all know how to diagnose neuropathic pain. And I think many of us, all of us, have faced some problem in our daily life. The patient come with Some symptoms like spontaneous pain, symptom like light touch painful, pressure painful, increased pain on pain prick, cool and warm, temperature painful, and sometimes the feeling of insect crawling over the skin, and numbness, tingling, loss of sensation. All these patient presented with neuropathic pain. Examples. I think we all face this type of neuropathic pains like post-herpetic neuralgia, diabetic neuropathy, cancer or drug-related neuropathy, trigeminal neuralgia, nerve root pain, post-surgical, and phantom limb pain. There is a graphical presentation of peripheral neuropathic pain and central neuropathic pain. They are the typical distribution. By this, we can diagnose the neuropathic pain. COVID-19 and neuropathic pain, a new entity. A retrospective analysis of post-ICU patient after COVID-19 infection found that 94% had pain at discharge, while 23.5% was suspected of neuropathic pain with lower levels after receiving ketamine as a part of their sedation regime. In recent studies, neuropathic pain screening questionnaire, new onset neuropathic pain for last 1 month was identified in 70 to 25% of the patient hospitalized previously for COVID-19 infection. So we must consider COVID-19 as a cause of neuropathic pain. In the assessment and diagnosis, we follow the normal rules. We have to take history, physical examination, and there is some validated pain scale like the Leeds assessment of neuropathic system and signs, Doliner neuropathic pain. All these pain scales can be used to assess neuropathic pain. Investigations, we do some routine investigations if we think like blood test. If we consider compression neuropathy, you can have magnetic resonance imaging. We can have nerve conduction studies. But what is new? The new thing is quantitative sensory test. It is used to detect damage of small nerve endings, which sense temperature, and large nerve endings, which sense vibration. It is non-invasive test regulated by computer system that recognize how the isolated nerve respond to vibration and various temperatures. Laser evoked potentials are widely considered useful to identify damage among the somatosensory pathway and are widely used for assessing peripheral and central nervous system disease that cause neuropathic pain. Skin biopsy to assess epidermal innervation is regarded as the most sensitive tool for diagnosing small fiber neuropathies. And the last one, corneal confocal microscopy can be used to quantify corneal nerve fiber damage to small myelinated A delta and unmyelinated syn fibers in patients with peripheral neuropathy. Now management. There is a existing management. I will tell about the existing management and what the scope of further improvement. Multidisciplinary team care is the key component of management of neuropathic pain. Non-pharmacological and non-interventional therapies such as addressing their mental conditions, physiotherapy, exercise, massage should be initiated early to address issues such as depression, anxiety, pain, and sleep disturbance. My previous speaker told about depression. There is a question whether pain causes depression or depression causes pain. You have to evaluate it. If trial alone without pharmacological interventional strategies, it is recommended that these are limited to a duration of 6 to 8 weeks. We can trial. There is a step-ladder pattern. There we can treat chronic neuropathic pain with multidisciplinary care, pharmacological treatment with first-line drugs. First-line drugs includes tricyclic antidepressants, gabapentinoids, SNRIs, topical lignocaine, and capsaicin. This should be trialed over an average period of 4 to 6 weeks. Second-line treatment including tramadol or combination therapy. Tramadol is the currently recommended for exacerbation of symptoms only, with caution in the elderly. In this setting, a trial of SSRI, anticonvulsant, NMDA receptor antagonist may be considered. Third-line treatment includes interventional therapies such as epidural injection, pulse radiofrequency, and sympathetic blockade. Neurostimulation should be a trial over 1 to 4 week of period, with a positive trial being more than 50% pain relief and the patient being happy with the result. And the last one is low-dose oral opioids are recommended as fifth line due to limited duration of efficacy and the significant risk of side effects. Commencement should be with immediate release medication and should be trialed to the lowest possible dose. The patient should be then converted to slow release opioids. These are the common first line antidepressant drug we all prescribe. I am here, I wanted to elaborate these things because we are practicing this drug in our daily practice. Tricyclic antidepressant is still dead. Tricyclic antidepressant is the best drug to treat neuropathic pain. Tricyclic antidepressant includes nortriptyline, desipramine, amipramine, and imipramine. The major side effects you must know: conduction cardiac defect, sedation, confusion, and anticholinergic effect, orthostatic hypotension, and weight gain. Precaution should be taken in patient with a history of seizure, prostatic hypertrophy, urinary retention, chronic constipation, narrow angle glaucoma, and others. Contraindication: it cannot be prescribed in acute myocardial infarction or with a history of heart block. ECG screening recommended in older patient more than 40 years. SNRI. Two SNRI are used. They are duloxetine and venlafaxine. Duloxetine and venlafaxine has side effect nausea. All of have similar side effect like nausea, loss of appetite, constipation, sedation, dry mouth. It should be used in caution in patient with mania, seizure, bleeding tendency, and those with anticoagulant and a patient with hypertension. The main side effect is hypertension. Gabapentinoids. Gabapentinoids, gabapentin and pregabalin has been used for neuropathic pain. They cause sedation, dizziness, weight gains, edema, both of them. They are good drug, recommended, but follow-up should be done for weight gain, weight gain and other in diabetic patients. Now what is new? The new drug is mirogabalin, a selective ligand for the two subunits of voltage-gated calcium channel developed for the management of neuropathic pain, the next generation neuropathic pain reliever. Mirogabalin, the next generation neuropathic pain reliever, in January 2019, first approved in Japan. 200 clinical trials worldwide. Mirogabalin is expected to become fourth USA approved drug therapy for DPNA, following pregabalin, duloxetine, and tapentadol. Mirogabalin shows greater sustained analgesia due to high affinity to alpha-2 delta-1 subunits and slow dissociation from alpha-2 delta-1 subunits in the dorsal root ganglia. Additionally, it produces a lower level of central nervous system specific adverse drug reactions due to low affinity to alpha-2 delta-2 subunits and rapid dissociation from the alpha-2 delta-2 subunits in the cerebellum. Efficacy of 30 milligram mirogabalin has equal efficacy with 600 pregabalin and 1200 gabapentin. Mirogabalin is better than pregabalin because it has greater efficacy and increased analgesia. Pregabalin binds both equally with the alpha-2 delta-1 and alpha-2 delta-2 subunit. For this reason, it has lower retention of analgesic effect and higher chance of adverse drug reaction. Whereas mirogabalin has strong affinity to binding with alpha-2 delta-1 subunit, but lower affinity, quick dissociation from the alpha-2 delta-2. That's why it has higher retention of analgesic effect and lower chance of adverse drug reactions. Why does the body do mirogabalin? Active absorption in the gastrointestinal tract, 90% bioavailable. Food may be delay absorption. Active transport across blood-brain barrier into voltage-gated calcium channel of dorsal root ganglia, 75 to 80% elimination unchanged in urine. So mirogabalin is better than pregabalin. It has a quick onset of action and lesser side effect profile. Long-term safety in a study, long-term safety of efficacy of mirogabalin in Asian patients with diabetic peripheral neuropathic pain of 14 patients who entered the study, 172 completed extension study of 52 weeks. 149 received the highest dose of mirogabalin, that is 15 milligram twice daily. The most common treatment emergent adverse effect was nasopharyngitis, diabetic retinopathy, peripheral edema, somnolence, diarrhea, increased weight and dizziness. Most treatment emergent adverse effects were mild to moderate in severity. The incidence of treatment emergent adverse event leading to treatment discontinuation was 13.1%. The visual analog scale of all other short form of McGill pain questionnaire subscale, sensory score, affective score, total score, present pain intensity generally decreased over time to baseline until the week of 52. So it has a long safety profile. So it has established that it can be given up to 52 weeks. It is proven safety in renal failure. Mild renal failure, it can be given with normal dose, but dose should be reduction in moderate to severe renal failure. We must talk about diabetic peripheral neuropathy because most of our patients came to us with diabetic peripheral neuropathy. Specific treatment to reverse underlying nerve damage is currently not available. So, glycemic management can effectively prevent diabetic peripheral neuropathy, but it does not reverse the neuronal loss. The most common early symptoms are induced by the involvement of the small fibers, include pain and dysesthesia, unpleasant sensation of burning and tingling, and the involvement of large fiber may cause numbness and loss of protective sensation. Electrophysiological testing or referral to a neurologist is rarely needed, except in situations where features are atypical and diagnosis is unclear. Patients with diabetes mellitus have alteration. Why there is neuropathy in diabetes mellitus? Patients with diabetes mellitus have alteration in the peripheral and central pathways, pain pathways. Other mechanistic contributors include blood glucose instability, increased peripheral nerve epineural blood flow, microcirculation of the skin of the foot, altered intraepidermal nerve fiber density, increased thalamic vascularity, and autonomic dysfunction. There is a new concept in diabetic neuropathy. Methyl glyoxal, a byproduct of glycolysis. Plasma level are increased in patients with diabetes mellitus owing to the excessive glycolysis and decreased degradation by the glycoxylase system. This metabolite activates peripheral nerve by changing function of the sodium channels and therefore have a role in painful neuropathy. A recent head-to-head trial suggested that therapeutic equivalency for tricyclic antidepressant, SNRI, and gabapentinoids in the treatment of pain in diabetic peripheral neuropathy. The trial also supported the role of combination therapy over monotherapy for the treatment of diabetic peripheral neuropathy. All gabapentinoids, pregabalin, gabapentin, mirogabalin has effect on diabetic peripheral neuropathy. SNRI, tapentadol can be used in diabetic peripheral neuropathy. Tapentadol and tramadol are centrally acting opioid analgesic. They have chance of addiction and should be avoided whenever possible. Tricyclic antidepressant can be given, but it has side effects to restrict its use over the age of 65 years. Sodium channel blockers can be used. Local drugs like capsaicin cream and lidocaine patch can also be used diabetic peripheral neuropathy. Other drugs. There is a compelling indication that oxcarbazepine and carbazepine are the first line treatment for the trigeminal neuralgia, and the rate of success with these agents in treating this disorder have been considered to be good. So, no one drug is effective for all patients, as pain relief is usually partial and side effect limits tolerability. Note surprisingly, 45% of those with neuropathic pain utilize two or more medication for their pain. In diabetic peripheral neuropathy, nortriptyline plus pregabalin and imipramine plus pregabalin was shown to be more effective at decreasing pain than monotherapy. All about this drug and the interventional method. Some interventional methods are effective treatment approach against neuropathic pain. These are effective in neuropathic pain. Clinical interventional techniques are those techniques that are currently practiced or used in human pain management. These techniques may include spinal cord stimulation, steroid injection or neural blockade, transcranial or epidural stimulation, deep brain stimulation, percutaneous electrical nerve stimulation, and neuroablative procedures. So, what is the impact of chronic neuropathic pain? It causes anxiety and depression. It causes muscular weakness. It causes disability. It decreases quality of the life, affect mobility, balance, and coordination. What are the challenges? I am at the last part of my presentation. What are the challenge of managing the neuropathic pain? Challenges in pain management, in particular patients' population. Suppose those patients who are debilitated or dementia, they cannot say pain. So these are the challenge in diagnosing patient. Limitation in currently available medication, as I have said earlier. Inadequate efficacy. No drug is 100% effective. Major side effects. Dose escalation is not possible due to development of side effects. Treatment cost. The newer drugs treat more cost than the older drugs. A strong referral system should be established. If a patient is not improved, where we should refer the patient. So there should be a strong referral system. Lastly, we should establish a pain clinic all over the country under the guidance of internists. Thank you all. Thank you for your patience hearing.